Good morning. I am so excited to be here this morning and the honor. Thank you to the Academy and to Academic Emergency Medicine for inviting us to talk today. And I'm thrilled to share the stage with a colleague and hero of mine, also Dr. Wintemute. And we're going to be sharing this presentation today, and I'm going to focus my part of these talks on children and youth primarily. And so I think as we gather here in Las Vegas, we're about a year and a half after a horrendous shooting, mass shooting. We're here today to honor those victims and to honor them with our action in emergency medicine. And I want to spend the next 15-20 minutes talking to you about how we in emergency medicine and emergency physicians can take action and move forward. Setting the stage for us a little bit today, some background. So among children ages 1 to 19, those who live through infancy in our country, firearm injury is the second leading cause of death. This is a great surprise, as I think really as the data becomes more clear over the past couple years to many across the country. We're very familiar with motor vehicle crash being the leading cause of death among children for quite some time, and cancer being a leading cause of death among children for many years. But these facts around firearm injury and firearm death have been a little bit more obscure, and so I'm going to just pause for a moment and go into them in a little bit of detail. Among children 1 through 19, homicide is about 60% of the firearm injury deaths among this age group. Suicide, about 40%. Unintentional or accidental shootings, about 3 or 4%. Representing overall about 3,000 youth ages 1 to 19 who die every year. I want to really focus our framing today around this as a public health problem. We're emergency physicians. This is a health issue. To quote the famous Surgeon General David Satcher, if it's not a health issue, then why are people dying of it? As there's a lot of discussion on, is this a criminal justice problem? Whose problem is this? What problem is this? In the House of Medicine, let's be clear, this is a health issue and a public health problem. So where have we come? How have we gotten here? That was a really great overview and segue to this talk on the history of emergency medicine, the Academy here of Academic Emergency Medicine. So over the last 20 years, this is a snapshot of where we have been among deaths, the leading causes of death, these 10 leading causes of death for children. Many of us, myself included, who have stood at the bedside of these children for the past 20, 30 years as a specialty. So from 1999 to 2016, we can see, and rings true, I think, for what we feel individually from our clinical experience, that motor vehicle crash has been overwhelmingly the leading cause of death among youth. That third line here, I don't think I have a pointer, that third line here, malignant neoplasm, has been the third cause of death. Going back through the 1990s was a higher cause of death before that. But really has remained in that third position. Firearm-related injury, that orange line, has been very stable over my whole career. And as I reflected on this talk, putting together slides, I realized that inadvertently, as we had created this data, 1999 was the year that I actually graduated my residency program. And so I think for those of you that are residents out there just starting your career, that sort of struck me very smartly. So actually, when I started my career, the cause of death for crash has halved just over the course of my clinical lifetime in 20 years. Has gone from 10 per 100,000 children to 5 per 100,000 children. So we want to focus today on how we can take that orange line over the course of the career of you residents in the room and you junior faculty in the room in the next 20 years, and how we can half that rate. We look at that line and we see in about 2013-14, there's a little bit of a concerning uptick. That uptick is real and it's significant, and it represents about a substantial increase in both homicide and suicide by gun among children in our country. Whose community is affected by gun violence? I think this is somewhat of a confusing question, actually, for emergency physicians when I speak. So if we look at this graph, we see that actually among urban, suburban, and rural youth, the rate of children dying by firearm is about 4 per 100,000 in all of our communities. And when I talk, this is really quite surprising to many. They say, well, I work in an urban area, and so, I work in sort of a knife and gun club, and this feels true to me. And when you speak in more suburban areas or rural areas, they say, that doesn't really ring true to me. I don't see these youth coming in. And this is where I remind you that that suicide line, which is more typically the rural and suburban rate of death there by gun, those youth, 95% of suicide attempts by firearm are fatal. Those youth don't make it to your trauma bay. They die on scene. They go directly to the morgue. Yet the rate of death among children by firearm is the same in about all of our communities, about 4 per 100,000. It's important to touch on school shootings and mass shootings. We stand here in Las Vegas, a scene of a horrendous mass shooting. These shootings have been incredibly important, both for how horrific they are, as well as for raising the awareness in the country of how much gun violence touches all of our lives. We realize the citizens across the United States have realized that firearm violence, something that we've seen really close up for many years in all of its ravaging wounds and the way it's almost a war among our children and the wounds that it inflicts, hasn't been apparent to the American public. It's been very sanitized over the past 20 years. These shootings have really raised the awareness that firearm violence is a problem in all of our communities, in all of our houses of worship, in our yoga studios, at our music festivals. There is in our schools for our children. And that's been a really important moment and an awakening for the country. As important as it is, as we talk about this today from a data perspective, it's also important to know that school shootings particularly represent 1% of the deaths of children by firearm in the country. So bringing us back to where we're the most comfortable, the trauma bay, our trauma bay, where we stand. So what do we know about the people who come in through our trauma bays who are teens and youth? What do we know if we do nothing? What's the natural history of this disease? Our team looked a few years ago in Flint, Michigan in an NIH-funded study. We followed youth over 2 years, and we found that the youth who came in with an assault-related injury, not even just firearm, just an assault, could be a fight. We followed them for 2 years, and we found that about 60% of those youth over the following 2 years had some subsequent experience with firearm violence. Could be victimization, perpetration, being threatened with a gun. 8% had a fatal or non-fatal firearm-related injury, and almost a 1% mortality. I want you to tuck that away and think for a minute how much time we spend learning how to risk stratify patients for chest pain for their subsequent MI outcome. And then think about what we're doing with these youth and what the natural course of care is. This is us for emergency medicine. So we know, looking at those statistics, that we need to work more upstream. We're comfortable in our trauma bays. We know how to run trauma codes. We're incredibly good at acute resuscitation. What else do we need to do, and how is that part of our job? From a public health model, we need to work upstream. We need to think not only about the youth when they're there in the trauma bay, the same way that we talk to the person who's come in with chest pain, and think about what's going to happen to them when they leave our care and what their cause of death is over the subsequent year. And then we also need to think about all those youth that I just talked about that don't make it to our trauma bay but die by gun violence, by suicide, and what our interaction is with them and how we can change that. So what can you do? This is a call for us to action. So the first thing I implore you to do is to strike the word gun control from your vocabulary. Gun control is something that was handed to us. That's not our narrative. We don't talk about controlling our patients. We talk about safety. We talk about prevention. We need to start talking about firearms again. We need to say the F word. Firearms. We need to say it in our research. We need to say it in our practice. We need to say it in our professional societies. I am so excited to be able to have this conversation here today. I remember a time in many of our professional societies where we couldn't talk about firearms in the rooms. It was too political. That's no longer acceptable. This is the second leading cause of death among the children in our country. We have to be able to say the F word. Cars are not going away. Taking cars away is not the solution to safer transportation in 2018. That rate of decrease that I showed you for youth dying in cars, we have more cars on the road than we did in 1999. We have more miles driven. There are many solutions to this problem that can respect the culture that we live in. I understand fully that the safest home is one without a pool. I also ask you, how much judgment do you have for your patients when they have pools in their home? We don't tell them everyone has to get rid of their pool. We talk to them about safety. We talk to them about protecting their children. We talk to them about guardrails. We need to think about this non-judgmentally and what we can do for prevention and for safety. What else can you do? In your practice, None of us learned during residency or over the last 20 or 30 years in this society or any of our academic conversations how to have any conversations with our patients on firearms. So we need to educate ourselves now. We have to get up to speed. We have to get knowledgeable about guns and safe storage. If you'd never seen a car seat before, if you'd never had any orientation or lecture on car seats, could you have a credible conversation with a patient about how to wear a car seat or why should they wear a seatbelt if you weren't comfortable saying the word seatbelt or having that conversation? I think not. These are our patients. A third of children in our homes across the country have a gun in their house. We don't get to pick in emergency medicine. If there's one thing we don't get to pick, it's who we see. We see who comes in the door, and a third of the kids that come in the door in our country live in a home with a gun. We have to talk about that and talk about that with families and get comfortable talking about it. We can't simply look away. So what can we do? Some practical guidance. Our team, the Firearm Safety Among Children and Teens Consortium, is an NIH-funded consortium. And we have put together a number of resources and are doing a whole bunch of research, which I can talk about later. But one of the things that we're doing is if you go to our website, which is here, childfirearmsafety.org, there is a button at the top, which is Education and Training. And on that, you'll find a number of practical resources for physicians on how to get oriented on this conversation, including a video by gun-owning physicians, basics, not asking you to become an expert in firearms or an expert in ammunition. This is just orientation, being comfortable knowing what is a safe storage device, what is a cable lock, getting comfortable and an orientation to the conversation and to the topic. In a see one, do one, teach one model, we have a set of videos which demonstrate to you how to have a non-judgmental conversation with your patients on safe storage. How to have that conversation with families of young children, teens with depression, youth at risk for peer and dating violence. We find families are not opposed to talking about this, and it is not illegal in any state in the union to have this conversation. This is part of what we do. This is certainly our lane. What else can you do? In your emergency department, I ask you to recognize that the leading cause of death for teens, I'll say again, the leading cause of death for teens in our country is firearm injury. We have to address that. Support evidence-based screening for teens at risk for gun violence after your ED visit. Change the natural history and observational study that I showed you before. Support evidence-based violence prevention programs. We need an evidence base here at a time when the country is incredibly polarized. What solution works and what solution doesn't work has to be guided by the evidence. Should we arm everybody? Should we do very realistic school drills? We need evidence to guide us, and we need to support the evidence base that can get us there. Our team, about 4 years ago, developed a safety score. More research is certainly needed, but this safety screen, think of it as a CAGE score for firearm injury. For youth 14 to 24 in urban emergency departments, these 4 questions risk stratify your youth. Youth that score 6 to 8 on this have an 80% chance of having a firearm involvement engagement over the subsequent 2-year period. Think about how we risk stratify our chest pain patients. Why are we doing nothing currently with these patients, and how can we change that? Safer Teens is a program our team developed about 4 years ago in 2 randomized control trials, one with the NIH, one with the CDC. We demonstrated that this counseling session, which takes about 30 minutes in an urban ED setting, decreased the risk of subsequent peer violence, partner violence, over the next year. It's been demonstrated to be cost effective and is now listed by the CDC as part of the best practices for violence prevention. In our hospital in Flint, Michigan, it's delivered by child health staff. It can be delivered also by nursing staff. Is this important? I know we do a lot, and how can we possibly do more? And I'll bring you back to the idea. The leading cause of death for every teen we see in our emergency department is by firearm. And how do we change that? And is that not part of our job? Outside your practice, we can advocate. Your physician voice, if there's anything that we learned in 2018 with the This Is My Lane movement, is your physician voice is incredibly important. You have a window into what is happening with gun violence that people in the country haven't had and has been far too long sanitized. You can advocate. Stand up and tell your patient stories. Talk to people. Advocate for research funding that's commensurate with the burden of disease. Over the last 15 years, cancer, I mentioned, was the 3rd leading cause of death for children, received about $335 million of funding. Firearm violence received 15. We need to advocate to be commensurate with the burden of disease. Support your professional societies and know who and what they support, and make sure that those are aligned. There's a number of professional organizations, many of whom started by physicians, including Research Affirm, started by emergency physicians Megan Rainey and Chris Barsetti, Physicians for the Prevention of Gun Violence, our group FACTS, as well as the This Is My Lane Twitter movement. These are physicians-oriented groups that are non-political, that are working on this issue. They have ways to get involved. Get involved. Or don't get involved. This was the Parkland students in DC. I was there that day, and it was even more impression in person. And we're a research-oriented academic group, and so outside your practice, research. Firearm injury prevention is a wide open field. The amount of questions that haven't yet been answered are mind-boggling and very low-hanging fruit. The funding is opening up. The Arnold Foundation has just given $10 million. The NIH is funding firearm research. I have $8 million by the NIH to do firearm research. There are K awards being given in firearm research. Just because the RFA doesn't ask for firearm research does not mean the NIH is not accepting investigator-initiated awards that will be peer-reviewed, and please submit them. New Jersey, California are doing state funding. There's postdoc positions that we and several organizations around the country offer that you can learn the specifics of research training around the specific science-based topic of injury prevention for firearms. We have a data repository on our child firearm safety website. It has about 50 data sets right now. We'll soon have 100 wide open for residents and postdocs who want secondary data analysis, low-hanging fruit. Do the research. So bringing us back, in emergency medicine and really in the House of Medicine broadly, we got off path in these last 20 years. There was a silencing of what was a really important cause of death. We have to get back on path, and I'm so excited and I have so much hope and optimism that we are now can be back on this path. Partly I have optimism because of gatherings like this. This is a picture this spring of 50 medical organizations brought together by the College of Surgeons to come to consensus around what we all believe across the House of Medicine is that this is a public health problem. This is a problem that we here sitting in this room are going to be able to address over the next 20 years. And I leave you with that thought of hope, and that this is indeed our work and our work in emergency medicine. Thank you so much for your time.